Hello and welcome. My name is Michelle Assetto. I'm a nurse working in the Chronic Pain and Wellness program. I'm here to talk to you about substance abuse. And what I want to discuss and introduce to you is not only talking about opiates and heroin and certainly the prescription painkiller problem that we have in our communities, but also starting to use a common language and discussing these issues as a chronic disease. So some of the objectives I want to cover are, first of all, understanding the basics and the driving forces behind opiate misuse and dependence, understanding opiate misuse as a chronic disease, learning to verbalize the signs and symptoms found during your assessments that may indicate possible opiate misuse or dependence issues, to make sure that you understand reflective listening, and to know different treatment options for opiate misuse and dependence. So, the National Institute of Drug Abuse defines drug abuse or dependence as a condition in which the use of legal or illegal drug causes physical, mental, or emotional or social harm. It also states that the drug usage impairs one's ability to function in daily activities of living and work environments. So, what I want you to take from that are some nursing points. When we do assessments, we want to look at these things as potential areas not only of things that are going wrong for the patient, but also places that we can start to look at as therapeutic and coaching points. So we look at things like illegal activity, physical harm, such as the patient getting abscesses from IV use, mental harm, emotional harm, social harm. There's a really big one when we are talking about does this involve family and children. Is patients' drug use impairing their ADLs? Is it impairing their relationships, which we know certainly happens inside of families? So I want to get back to the very basics, and I want to talk about what is your motivation? What are your basic instincts for survival? Um, we all know we need water, and we need food, and certainly as a species that we need procreation. Everything we do as a species, we do to ensure our survival. So, what does it have to do with drugs? Well, what would you do to protect yourself or your loved ones from hunger or thirst or even death? Well, I would venture to say that would be anything and everything. And let's ask ourselves why. Well, when we get right down to it, we have to go into the brain, and we go into the part of our brain that's called the limbic system. And some of us have had this education, and I think it's worth repeating if you have, and if not, I'm going to explain to you the basics. The limbic system is at the basics of what interprets and creates our emotional response. It stores our memories, and that's for sensory perception, and it's what regulates our hormones. It developed our ability to manage the fight or flight. It's the part of our brain that rewards us for repeating activities that allow us for survival. It's essentially what makes that chocolate taste really good. It motivates a person to repeat these activities over and over again through memories and triggers and rewards. Just think about how yummy baking bread smells. So, how does this all relate to substance abuse? Well, let's talk about that. I want you to think about dopamine, and it's starting to be a big word. We're hearing more and more about it. Dopamine is what floods our brain when we do a lot of things that involve the limbic system, and it's part of the reward program inside your brain, directly related to pleasure and euphoria. Reward, pleasure, and addiction, all connected. Now, the nucleus accumbens is part of the limbic system, and it is the most important area affected by drug use. And when we say drugs, we also include caffeine and nicotine in that list of drugs. All right. Well, how does this all affect the part of the brain? Well, when you use drugs and or create actions, it creates a cascade of events inside your brain. And whether that is exercise, and yes, exercise does create a cascade of events that floods the brain with dopamine, as do all of these other things in this list. Food, water, sex, and drugs all affect the same areas of the brain. And what happens is you get this response for the cells to make more dopamine, and the transport and the signals to the other cells to do the same. And the nerve impulse flies down the axon to the terminal ends, and the signal to make more dopamine happens inside the factories, and the factories make more dopamine, and they release, and the doors open into the synapse, and the synapse gets flooded with dopamine, and so on and so on. And every nerve in this line draws up more dopamine, and it just keeps happening over and over again until the brain is flooded with endorphins. And essentially, the brain feels great. More dopamine, happier brain. Well, the drugs are smart, and all drugs of abuse target the brain's pleasure centers. They trigger the dopamine, the brain gets flooded with dopamine, or the dopamine gets blocked from being received back up into the nerve synapses. These things happen normally when we do enjoy things like food and music and art. But when the drugs hit these things, the dopamine increases are exaggerated. The communication gets altered, and sometimes permanently. Well, why do we repeat the activity? Well, that's part of the limbic system. So there are certain triggers. We all know the smell of bacon means breakfast. The sound of an organ can mean circus. Places. I know that the sight of a roller coaster gets some people's heart racing, and it personally puts my stomach in knots. There are gateway drugs. I want you to ask anybody who smokes if they can drink coffee without smoking a cigarette. So we know there are gateway drugs, alcohol and marijuana being two of them, that will lead to other unfortunate drug use. Memories, PTSD, seeing abuse on TV can cause some serious fear in some people. This all comes out of the limbic system, that whole fight or flight. People, old flames can cause heart flutters. A long, hard day at work can make people want to drink. That's whole stress response. Pain, the avoidance of pain. The brain remembers these things, and they all cause an instant response in the limbic system. We also know that when a person uses drugs, they grow tolerance. And the more drugs they use, the more they end up needing. And this is a physiological and a psychological dependence on the drug that they're using, which then leads to a maladaptive behavior syndrome. This becomes the driving force behind chasing the high that they're getting from the drug, or they're actually getting from that huge dopamine response that the drug is creating in their brain. So let's talk about opiate addiction dependence. We can talk about prescription pills being what they're addicted to. And when you get addicted to prescription pills, these things can sometimes start innocently. And you start thinking about underlying issues. You have natural adolescent waxing and waning of dopamine when they get to certain ages. You have dysregulated dopamine systems from possibly pre-existing depression or alcohol use, environmental issues, and perhaps people who break bones and end up on prescriptions. And there are many other ways that people can end up on prescription pills, including illicitly. People who are addicted to heroin are 9 times out of 10 patients who end up on heroin because the cost of using street pills gets too expensive and hard to find. IV drug use, most people nowadays will try to avoid, but as the tolerance to the opiates grows, it's almost impossible. And because IV drug use is the most effective way to cross the blood-brain barrier, a lot of people do end up going to IV drug use, and that goes right back to tolerance, because it is the most potent high they can get to. So looking kind of more closely at the different types of misuse, and specifically at adolescent risk-taking behavior, and knowing that the teen brain naturally has that waxing and waning of dopamine levels during development, we have to be very careful to make sure we know that that is what's making them vulnerable to the drug use. And then you add on the peer pressure and the life stressors and the wanting to fit in, which all add to the problem. We have to be very careful to watch and monitor our teens. Depression. Opiates will activate a depressed brain if the dopamine receptors are malfunctioning. It will make a depression feel better. And sometimes when depression is something that is active with a person and that person goes into withdrawal, it will make that worse. And sometimes you will see people with depression who are also in withdrawal suicidal. There are other people who are susceptible to opiate dependence and addiction. We've seen several people who were previous alcoholics who now have a new drug of choice, and this question out there is if it's actually now regulating or normalizing their dopamine receptors that were just never corrected. And there is a lot of relapse that happens, and perhaps it's directly linked to the failed treatment options that have been out there. We go right back to the limbic system, however, and we talk about how it is all dopamine driven. It is food, water, and procreation. It is survival instincts. The drugs attach to the same area of brain, and the misuser actually believes that they will die without the drugs. And again, I say, this becomes the driving force behind the drug-seeking behavior. It is why you see the behavior from the patients that you see in your office. This withdrawal syndrome is something they want to avoid. They actually believe they will die. The brain is telling them that they will die, even though death from opiate withdrawal does not happen. But this is the driving force behind chasing the sick away. It is a very powerful sickness. This also tends to be the root cause of relapse, because once a person hits withdrawal, they do not want to stay there. And even if they are trying very hard to stop using drugs, being sick like this is something that will make them use drugs again. So we look at relapse rates, and we start talking about treating drug use and drug addiction as a chronic disease, and we look at the relapse rates for other diseases, which are similar and sometimes worse than drug addiction. We also look at how treatments are evaluated by comparison, and you look at outcomes, and they're very similar. So we want to look at treating this as a chronic illness because the outcome when treated actually can have a positive impact. Extended abstinence is a predictive of sustained recovery. And as you can see by this graph, if a person can stay in abstinence for 5 years, they are most likely to stay abstinent. This is why strong drug treatment programs are so needed in our communities. So let's think about, how do we treat a diabetic? Well, we use harm reduction. We don't expect our diabetics to stop eating cake, but we ask them to eat less of it. We use a non-judgmental approach. We certainly are using the patient-centered approach. We're coaching our patients. We're supporting our patients. We do a lot of teaching. We know our patients might relapse into eating foods that are not good for them. We adjust our patients' medications according to where they're at, meeting the patient where they're at. We try to involve the family when they can. And we know that there are other underlying conditions that exist because of or may have caused the problem. We don't know whether it's genetic or not. We also know that there's learned behaviors. So what we want to do is start looking at our other patients that have addiction and dependence and start using these same models for treatment. If we're going to treat dependence as a chronic disease, we should apply the same approach for patients with substance misuse challenges. The first question to ask, however, is the patient ready for treatment? Because it's not up to you as the medical provider. It's always up to the patient. And it is the patient's choice as to which treatment they want or feel is best for them. It is the healthcare provider's responsibility to remain non-judgmental. Remember, we want to think diabetes because there is no one way for all patients. So let's look at some statistics to help better understand the problem. The green shows us the sales per kilogram per 10,000 people of prescription drugs. Now these are specifically opiates. The purple shows us the deaths per 100,000 people who have died from overdoses of opiates. And the orange shows us the treatment admissions for opiate addiction. Now we've seen a decrease in treatment for alcohol abuse over the years. This is 1994 to 2004, and as you can see, there are less people going into treatment for alcohol abuse. And if you cross-reference that with the admissions over somewhat the same 10-year period for opiate, non-opiate, non-heroin per state, we see some very sharp increases. This is the heroin admissions rates per state. And as you can see, back in the 90s, there were more. There was a slight decrease, and now we're on the rise again. And that most likely is because we're seeing more and more people starting to use pills. And as they get more and more expensive, people are going back to using heroin because there are less and less pills available on the street. What are the solutions? Well, treatment that matters is one of them. Being delivered in a meaningful way, and possibly now through a patient-centered medical home. Let's look at the possible medical treatment options. Methadone has been around for a long time. It is a mu receptor full agonist. You do build up tolerance to that. Few people are successful in ever getting off the medication. However, they do have success in staying on in good, strong, structured programs. There are, however, many who continue to use other drugs while they are on the methadone. There is buprenorphine, which is Suboxone, which is a mu receptor partial agonist. It's highly successful with motivated individuals. It's a safe maintenance program if it's highly monitored, but it also can be diverted, sold, or shared. There is Vivitrol, which is a mu receptor antagonist. It has been recently approved for opiates and has been showing promising results. And there's also a holistic approach, either alone or combined with any of the above. And this utilizes exercise, mindfulness, nutrition, hydration, and sleep, among many others. Specifically, let's talk about methadone. Methadone is a full opioid agonist. It does carry a social stigma. It has many nicknames like liquid handcuffs, ball and chain. Most patients have to go either early in the morning, although I do believe some of them dose up till 11 o'clock every day. And if a patient is motivated, they can do well. Many people stay on methadone for long term. It is difficult to wean off. The half-life is 24 to 36 hours. The withdrawal from methadone can take up to a month. The 1 time a day dosing is for dependence. The only time it is used for pain is in smaller doses more frequently, and this is discouraged by the methadone clinics. Urine drug testing should be for the metabolites, which do last longer in the system. Observed dosing is done in the clinic with long-term structured care. Patients go to group therapy. They are also allowed to go to one-on-one therapy. They have a lot of aftercare work. They're recommended to get back to jobs, and they encourage them to go back to school. Suboxone, buprenorphine. This is a partial opioid agonist, and what that means it activates the mu receptor. However, it does not allow any euphoria. It also acts as a blocking agent, so a person who's on Suboxone cannot take other opioids and get the effect from the opioids. Therefore, a person who is on Suboxone who were to take a Percocet cannot get high from that Percocet or get any pain relief from it. It does eliminate cravings and eliminates the withdrawal symptoms. It only has to be taken 1 time a day, and it's very effective at low doses. The patient actually feels normal. It has a 24 to 36 hour half-life, therefore the person carries their dose over from the next day so they can wake up still feeling normal from the previous day. With maintenance and monitoring, patients do very well. Support and coaching is very important, and as with the methadone, behavioral health and psychiatric support is strongly recommended. Patients can either wean off or stay on long term, and again, it is up to the patient to decide what their level of treatment should be. Unfortunately, there is a short supply of responsible providers in our communities prescribing this medication. It comes in both the pill form and a film form. Both are placed underneath the tongue. The drug occupies the receptor once it gets into the bloodstream and into the brain, so it calms down the receptor that might be in withdrawal. Once it's actually in a sustainable dose, there is no longer a withdrawal. When you compare the film to the tab, you can see that once the medication's on board, there is no change in its efficacy or its lasting effect. It has been abused. Some people have even smuggled it into jail. The form of it that has no naloxone can be injected. It's one of the reasons it's not prescribed except in pregnancy in a highly monitored program. But most patients who are on Suboxone in responsible medical treatment programs are invested in improving the quality of their lives and few abuse the drug. Those who do are usually sabotaging themselves out of treatment. Vivitrol is another medication, also known as naltrexone, now available in an injectable form. Once a month, a patient is injected in the gluteus. It creates a blockade to both opiates and alcohol. Currently, there's a program going on in the jail system where inmates are being given this injection prior to release, and it is showing excellent results. A couple of the drawbacks is the soreness at the site, and it also is expensive. However, many insurance plans are covering it. There are not enough providers using the medication yet. However, we do hope to see this in the future. It is given in the physician's office with a deep IM injection. The RN can administer it, and very few patients have reported any side effects other than soreness at the site. When we compare those three medications, we can see that methadone is a full agonist and can lead to CNS depression and death. Buprenorphine, otherwise known as Suboxone, is a partial agonist, and it has a ceiling effect and cannot reach to that point. Naloxone has no opiate effects. We know that treatment reduces recidivism. We have the statistics to prove it. Patients who come out of jail and go straight into treatment have much better outcomes. And we take those treatments and we add all sorts of holistic approaches to them. Please think about referring your patients to one or any of these, psychotherapy being one of the most important ones. Think about art. Think about yoga. Think about exercise. Think about dopamine. Something most people have heard before, however, it's something we need to start thinking about when talking to our patients, because most have insomnia. This comes from a lot of different reasons, and a lot of it is from anxiety, a lot of it because most of our patients smoke cigarettes. We need to start thinking about smoking cessation. Hydration is another problem that most of our patients don't hear out of their limbic system, that thirst and hunger are also shut off. So encouraging their patients to drink water is important for your nurses. Encouraging patients to get back to work or go back to school. Getting that sense of accomplishment. These are all treatment adjuncts. Continued non-judgmental support is by far one of the most important signals your patient needs to hear from you. In treating addiction, we need to keep our eye on the real targets: abstinence and functionality in both family, work, and community. So how do we start that conversation? Well, let's think about what prevents people from asking for help. Shame prevents honesty. Discomfort, fear, and distrust. Hopelessness. Everyone passing judgment, and this includes healthcare workers. Some believe they're being prescribed so they can't be a problem. Some have never been taught about how the brain works. So empathy goes a long way. Motivational interviewing, which you will also be learning about, is something you're going to want to use all the time with these patients, with all of your patients. Always being respectful and treating your patients no different than you would a diabetic. You want to encourage your patients to open up without pushing. Remember, a lot of these patients have trauma in their background. The more comfortable the nurse feels about talking about the subject, the more effective the screening will be. So I encourage you to seek information and mentoring on this subject continuously. Whether the disease is diabetes, asthma, hypertension, or opioid dependence, an open dialogue between healthcare professional and patient is one of the most important factors contributing to successful treatment. Using empathy, demonstrating empathy for your patient's feelings conveys that you are listening and trying to understand their point of view. This in turn helps patients feel more comfortable about opening up and sharing details about themselves that may be relevant to their treatment. Use reflective listening. I understand. I agree. I see. You have every right to feel that way. Be non-judgmental. Avoid appearing judgmental. Avoid discussions or questions that your patients might interpret as passing judgment on them or their actions. Helps encourage more honest communication. Patients who sense they are at risk of losing your approval may feel pressure to hold back or tailor their responses to fit what they believe you want to hear. Be confident. Project confidence and knowledge. Remember, seek knowledge. Patients are more likely to be honest with healthcare professionals whom they perceive as able to provide or facilitate the care those patients need. Projecting confidence and knowledge communicates that you are someone patients can rely on to help them. Again, in repeating myself, the ability to demonstrate reflective listening. Repeating what the patient has said to confirm that patient is being understood. Empathetic, non-judgmental. Being confident, professional, and supportive. Respectful and patient-centered. Genuine and affirming. People initiate change when two basic conditions are met. When they, as the patient, decide they want to change their behavior, and when they, as the patient, feel strong enough to face the challenge of changing their behavior. So screening questions, therefore, are not designed to put the patients on the spot or make them feel ashamed, as neither of those will encourage change. Instead, the goal is simply to learn as much as possible about the patient's condition. So here's some tips. Keep the questions straightforward. Direct. Don't use street terms. No slang. Use simple language rather than medical jargon. They don't speak in medical jargon. Don't speak that to them. Targeted open-end questions. You'll get more information from them. Tell me about how this drug affected your life. In the past, what things helped you stop using? How many physicians have you seen? How many pharmacies are you using? When there are some other indications of drug use, use some assumptive questions. When was the last time you used drugs? Have you ever used drugs? Have you used drugs other than those required for medical reasons? Now here's some interesting words I want you to start thinking about shifting. Have you misused prescription drugs? Get away from using the word abused. The minute you used abused, you set a negative tone to your conversation, and I guarantee you that patient will shut down. Do you misuse more than one drug at a time? Can you get through the week without using drugs, other than those required for medical reasons? Are you always able to stop using drugs when you want to? Do you misuse drugs on a continuous basis? So this is right out of SAMHSA. To facilitate early identification, intervention, and treatment of substance abuse problems, SAMHSA recommends routinely screening all patients for signs of substance abuse. Screening is also recommended in response to patient complaints about conditions that are attributable to opioid use, including physical problems, emotional problems, psychosocial or behavioral problems. When we think about those sleep disorders, and we think about that anxiety, and we think about people who miss work and school, those are red flags for us as nurses to start thinking about screening our patients. And be direct, because being direct with patients about opioid dependence reinforces to them that this is medical illness. This is not a moral issue. This in turn tells the patients that it is okay to talk to you about their condition. So in summary, the limbic system is the driving force for survival. Remember, the drugs hijack that mechanism. Opioid dependence can come from a variety of sources, including environment, adolescence, untreated mental illness, previous alcoholism, gateway drug use, etc. Relapse is common for all chronic diseases. The patient has the right to which treatment to go to and when to start, and communication with patients should be direct, empathetic, and non-judgmental, as well as reflective. I hope this webinar has brought you some information you may not have known. I'm available for any questions, should you have any in the future. Thank you.